Imagine you're me, a dashing chocolate wonder straight out of Willy Wonka's chocolate factory. I'm just kidding. But imagine you're working in the emergency department and a young female patient presents to the ED with right lower quadrant abdominal pain. Can you think of 5 possible diagnoses for right lower quadrant abdominal pain? How about 10? How about 15? 25? This is a little game I like to play, honestly, to keep me on my toes, keep me frosty with my diagnostic prowess, with ice in my veins. But when the moment presents itself, you have a strong differential diagnosis, and this game ensures that I do. If appendicitis was somewhere on your list, you got the right diagnosis for this particular patient. So good job. Today, we're going to take a deep dive into a common yet often challenging medical condition known as appendicitis. So appendicitis is the most common cause of acute surgical abdomen worldwide. It predominantly affects individuals between the ages of 10 and 30. Though it can occur at any age, gender-wise, it's slightly more common in males than females. The lifetime risk is estimated at 7 to 8%. That means if 100 of your closest friends are watching this video, 7 or 8 of them are going to end up with appendicitis at some point. They're going to be coming to see me in the emergency department. But let's do a quick anatomy recap. The appendix is a small tube-like organ attached to the large intestine. It doesn't really play a crucial role in the human body or function. But appendicitis occurs when the appendix becomes inflamed, usually due to obstruction by feces, like a fecal lith, a foreign body, or rarely a tumor. This blockage leads to increased pressure, decreased blood flow, and increased bacterial growth, which can result in inflammation, infection, and ultimately, if left untreated, rupture. Patients with appendicitis typically present with abdominal pain, which initially manifests around the umbilicus and then localizes to the right lower quadrant at McBurney's point. McBurney's point is located 1/3 of the distance from the right anterior superior iliac spine to the umbilicus. This roughly corresponds to the most common location of the base of the appendix, where it attaches to the cecum. McBurney's point is named after Charles McBurney, who published a treatise on appendicitis in 1891, in which he described the exact point on the abdomen at which tenderness was maximal in cases of acute appendicitis. And this point today is now called McBurney's point. Now, what other symptoms patients might have? Anorexia, nausea, vomiting, fevers, obviously the right lower quadrant abdominal pain, sometimes an elevated white blood cell count. But what physical exam findings will the patient have? They obviously have pain to palpation at McBurney's point. Sometimes they may have some rebound tenderness or guarding. They may have a psoas sign, or an obturator sign, or a Rovsing sign. So psoas sign is right lower quadrant pain on thigh extension while lying in the left lateral decubitus position. So we're on our left lateral decubitus position and right lower quadrant pain when we extend the thigh. The obturator sign is right lower quadrant pain with internal rotation of a flexed right thigh. Just imagine doing the stanky leg. That's going to cause a lot of pain. Rovsing sign is when we palpate the left lower quadrant, it causes right lower quadrant pain. It's like I'm palpating one side and they experience severe pain on the other. Now, atypical presentations occur more commonly in elderly. Some of these atypical presentations can include diffuse abdominal pain, absent leukocytosis, or absent fever. A high yield point is in elderly patients who present with diffuse abdominal pain You cannot forget to get an EKG to rule out acute coronary syndrome. Now, in pregnant patients, the pain of appendicitis may be a little bit above the right lower quadrant, and accompanying symptoms often include fever, nausea, vomiting, and loss of appetite. It's imperative to note that symptoms can vary, especially in children and elderly, making diagnosis challenging. So what are we going to be ordering? Now, if we suspect the patient has appendicitis, we're oftentimes going to order a CBC, a CMP, coags, type and screen, a UA, possible beta HCG in female patients that we suspect may be pregnant, EKG, obviously analgesics and antiemetics, and even a normal saline bolus sometimes. Clinical picture will often drive the index of suspicion, however. If the index of suspicion is high, no one should fault you to consult general surgery early. Obtain a surgical consult early. How are we going to diagnose appendicitis? The diagnosis of appendicitis can be tricky. It honestly starts with a thorough history and physical exam. Laboratory tests often show elevated white blood cell counts. However, imaging has revolutionized the diagnosis of appendicitis. Ultrasound is a good first-line modality, especially in children and pregnant women, to avoid unnecessary radiation exposure. Pregnant patients have the same risk of appendicitis as the general population. Pregnant patients with appendicitis often experience it in the second trimester. MRI can also be used in pregnant patients as well. But the CT scan offers a much more detailed view and is highly accurate, and is oftentimes one of the imaging studies of choice if they're not pregnant or a child. So what's the treatment for appendicitis? Well, once appendicitis is diagnosed, prompt treatment is crucial to prevent some of these life-threatening complications like rupture. The standard treatment is surgical removal of the appendix, known as an appendectomy. This can be performed via an open or laparoscopic approach. In very select cases, especially where surgery poses high risk, antibiotics may be used as a non-surgical treatment. Obviously, we're going to be treating these patients with analgesics and antiemetics, and sometimes it's good to note that short-acting, potent opioid analgesics are preferred to allow for more frequent reassessments. We're going to be giving the patient antiemetics such as Zofran or Compazine. We're going to give them a fluid bolus if the patient has been vomiting or evidence of dehydration. We're going to be giving them antibiotics as well, either ceftriaxone and metronidazole or Zosyn. We're obviously going to obtain when they last ate, and from the time they enter into the emergency department, make them NPO, nothing by mouth. So, what are the complications of appendicitis? One of the most dangerous complications of appendicitis is rupture. A ruptured appendix can lead to peritonitis, a severe infection of the abdominal cavity, and or abscess. Now, these complications can lead to sepsis and septic shock. These complications require much more extensive treatment and can significantly increase morbidity. Uncomplicated appendicitis has a mortality rate of 0.1%, but this mortality rate exponentially increases to 3 to 4% with perforation. Now, preventing appendicitis is challenging as the exact cause is often unclear. However, a diet rich in fiber may reduce the risk. The prognosis after appendectomy is generally quite good. It's actually excellent, with most individuals recovering without long-term consequences. So, although 7 of your 100 closest friends will end up with appendicitis at some point during their life, you'll still have 100 friends. Unless that appendix ruptures, and things might get a little dicey. But in general, you'll have your 100 friends. That pretty much covers appendicitis in a nutshell. I think we pretty much covered all the potential PIMP questions that you might run across. But this is a very dangerous diagnosis that requires rapid diagnosis and treatment to avoid potentially life-threatening complications. But you got this. The next time you have a patient that comes in with right lower quadrant abdominal pain, I'm sure appendicitis is going to be pretty high on that differential. As always, keep your head up. You're doing great. You're better than what you were yesterday. And that's a lot. Learn something new today. Going to be a great doc. Sometimes you just got to hear that.